رجب هاني أستاذ الأشعة بالقصر العيني، وهو من أحد رواد الكاردياك إيميجينج والمتحمسين للتخصص. صراحة وقته ثمين ومحاضرة ثمينة، وأحسن ما في المحاضرة صراحة الصور الإيميجينج في منتهى الروعة صراحة. ننتقل لأخونا العزيز الأستاذ الدكتور محمد عبدالفتاح، أستاذ الأشعة المساعد في جامعة الأزهر وأستاذ الأشعة في مجد يعقوب، وهو جاي من أسوان مشكورا على المحاضرة على طول. فاحنا يعني ايه يعني نشكرك.
السلام عليكم. طيب my talk today will be about double chamber right ventricle. That's our agenda. First, we will start with some brief for right ventricular anatomy. The right ventricle is composed of three components. Inlet portion, it surrounds the leaflets of the tricuspid valve and the subvalvular apparatus. Apical portion, characterized typically by heavy trabeculations, and outlet portion including the infundibulum and pulmonary valve. So what is the infundibulum? The pulmonary infundibulum is a tubular muscular structure that supports the leaflets of the pulmonary valve. Let's talk about the trabeculations of the right ventricle. The supraventricular crest, the posterior wall of the infundibulum is formed by the prominent muscular ridge known as the supraventricular crest, which separates the inlet and outlet components of the RV. It's formed from the free edge of the ventriculo-infundibular fold with a part of the infundibulum. It inserts between the limbs of the septomarginal trabeculation. The septomarginal trabeculation is a prominent Y-shaped muscular strap reinforcing the septal surface. It bifurcates into an anterosuperior and infraposterior limbs which clasp the supraventricular crest. The anterosuperior limb, it extends along the infundibulum to the leaflets of pulmonary valve. It forms the posterior wall of the infundibulum. The posterior limb, it runs into and overlays the ventricular septum towards the RV inlet, giving rise to the septal papillary muscle. The body of the septomarginal trabeculation extends towards the apex of the ventricle, where it gives rise to the moderator band. And the moderator band is considered as a part of the septomarginal trabeculation crossing the free wall of the ventricle and anterior papillary muscle before breaking up to general trabeculation. The septoparietal trabeculations originate from the anterior margin of the septomarginal tract and run along the right and left septoparietal walls of the RVOT. These trabeculations vary in number and thickness. There are three main papillary muscles in the RV: anterior, inferior, and medial or septal. The septal papillary muscle, sometimes called a papillary muscle of the conus, it's present in about 82% of the hearts, and in the rest it's replaced by tendinous cords. Now let's talk about the double-chambered right ventricle. Double-chambered right ventricle is a rare congenital heart disease in which muscular bundles growing in the subinfundibular area are hypertrophied, separating the right ventricle onto a high-pressure proximal chamber and a lower-pressure distal chamber. Double-chamber right ventricle is a subinfundibular obstruction, so it should be distinguished from the subpulmonic infundibular obstruction and its attendant causes like tetralogy follow. Various mechanisms have been proposed to explain the underlying pathophysiology of double chamber right ventricle. The earliest theories suggest that the obstruction is the result of increased blood flow among patients with ventricular septal defects, leading to hypertrophy of the supraventricular crest, superior displacement of the septomarginal trabeculation, and moderator band predisposes to the hypertrophy over time, leading to obstruction. Anomalous muscle bundles originate from the accentuation of the septoparietal trabeculations via muscular shelf that extends towards the right ventricle. The physiology is defined by the right ventricular pressure overload of the RV inflow chamber and rare cases the progression of RV failure. Depending on the degree of obstruction, the clinical course varies significantly in severity and the clinical presentation, with the most cases presenting to medical attention before adulthood. Although the substrate is congenital, the degree of RVOT obstruction is progressive with time. Types of double chamber right ventricle. Type 1 has an anomalous muscle bundle that crosses the right ventricle. Type 2 has parietal and septal muscle hypertrophy that is responsible for the obstruction, and they often are more likely to present with ventricular septal defect. However, the differentiation between them may be difficult in most patients. Associated defects. DCRV is exceptionally rare to occur as an isolated lesion. In about 90% of cases, there is associated membranous type of VSD. DCRV has been shown to develop in about 3% of patients with repaired tetralogy of Fallot. Other associations include conotruncal anomalies and Epstein anomaly. Imaging of DCRV. Transthoracic echo usually diagnostic but may show some limitations. Transesophageal echo may provide superior imaging in some adult patients. Multi-slice CT, assessment of hypertrophied muscle bands, anatomy and level of stenosis, assessment of the other associated heart defects, and dynamic subinfundibular obstruction can be assessed by retrospective imaging of the cardiac cycle. Cardiac MRI is the best modality following echocardiography, better than multi-slice CT in assessment of the level of stenosis and its severity, assessment of associated cardiac shunt anomalies, assessment of RV function, and assessment of associated valvular disease, and no need for contrast media. That MRI for a female patient about 20 years old with past history of surgically closed VSD. Double chambers right ventricle was suspected. Here we can find subinfundibular muscular hypertrophy during diastole with approximation of this hypertrophied band during systole and dephasing jet crossing that obstruction. Note the infundibulum itself is well developed, so it's a case of double chambered right ventricle with missed, a case of VSD with missed double chamber right ventricle. The same case with the RVOT view. You can find here that is the cresta supraventricularis, and that is a moderator band that show marked approximation during systole with dephasing jet across during systole. And here you can find that is the proximal chamber and that is the distal chamber. This case for a young man about 30 years old was diagnosed with double chamber right ventricle and MRI for confirmation. The RVOT view shows hypertrophied cresta supraventricularis with a subinfundibular ridge. Both exerts severe stenosis during systole with dephasing jet. Note here the moderator band is not involved in this case. And here is the distal chamber, and that is the proximal chamber. This case for a young man with small or very small perimembranous VSD with associated double chambered right ventricle, as shown in the MRI. There is subinfundibular muscular hypertrophy exerting stenosis, especially during systole. In all of these cases, note that the infundibular is well developed, no evidence of anterior conal deviation or pulmonary stenosis. That case is for a 14 years old boy with past history of repaired VSD. He presented with symptoms of pulmonary stenosis on examination that revealed there is a subinfundibular stenosis. There is marked dilatation of right ventricle with impaired function. That's short axis images or cine at the basal level. There is a subinfundibular hypertrophy of the supra ventricular crest and the septoparietal muscle bands with dephasing jet across during systole. The other view shows the RVOT, that is the hypertrophied muscle band, and anomalous band in the RV with dephasing jet across during systole. So it's a case of double chambered right ventricle. The last imaging modality is angiocardiography. Right ventricular angiography is excellent method to demonstrate the anatomy of the lesion. Anterior anterolateral projection demonstrate filling defects within the RV below the cresta supraventricularis between the outflow and inflow areas. Differential diagnosis: double chambered right ventricle can be mistaken for tetralogy fallot, isolated pulmonary valve stenosis, isolated VSD, pulmonary valve stenosis with a VSD causing a left to right shunt, and idiopathic hypertrophic obstructive cardiomyopathy affecting the right side of the heart. However, the location of the VSD can be helpful. In the VSD connects with the distal low pressure compartment, it will be present similarly to an isolated VSD. But if the VSD connects with the high pressure proximal compartment, it will present like a tetralogy fallot. That CT is for a young lady about 27 years old. She was diagnosed as tetralogy fallot. The image shows malalignment VSD or subaortic VSD. However, there is a subinfundibular stenosis, in this case with hypertrophied subinfundibular muscles, and the infundibular is well formed with no anterior conal deviation. So it is a case of a VSD with double chambered right ventricle. Conclusion: DCRV should be suspected with small VSDs. Transthoracic echo is usually sufficient for diagnosis of DCRV, but sometimes region between the RV inflow sinus and outflow tract is poorly visualized in standard planes, requiring a high index of suspicion. Closure of VSD may result in isolated DCRV, causing proximal right ventricular hypertension. Post-operative RV dysfunction may compound the ill effect of missed DCRV, RV hypertension, and pulmonary hypertension, if any. Thank you.
شكرا دكتور محمد. الحقيقه يعني حته صغننه صعبه جدا من عن سو رير ديزيز. فلو في اي كويستشن. دكتور محمد من الناس المتميزين الحقيقه في الكاردياك ايميجينج. هو
سلام يا دكتور محمد. سلام.
الدرجه دي.
سلام يا باشا.
في مجدي يعقوب انستيتيوت، يعني ناس كلهم بروميننت في الكاردياك ايمجنج الحقيقه.
شكرا استاذ دكتور محمد عبد الفتاح، محاضره قيمه يعني دسمه